I'm Dr. Dana Shreen. This is Where's Mr. Yuck? We're going to be talking about treating the toxic patient. All right, so sit down, hold on. It's going to be a fun ride. Okay, a lot of information today going through the toxicology patient and all that stuff. So what specifically when we talking about? Okay, going through, I built this is really from the perspective of the toxidromes. That's what I wanted to talk about was all the toxidromes. Hitting the major five, but there's actually more than that. But really going down that pathway. And then talk about some of the street drugs that are out there. And then of course, how do we handle the pharmacologically gifted individuals that we will see. All right. So if you think about it, okay, this is really on the brain side of it, of our desire pathway. All of it comes together. You have the amygdala, the substantia nigra, which is where the dopamine comes into play. So the two major hormones inside the body or inside the brain that really deals with a lot of the toxicology side of it. On the pleasure side is dopamine. That is your schizophrenics. If they have too much dopamine, that's how they get the way. On the flip side of it, the Parkinsonian, how they're very slow, you take the dopamine away from that. But it's the dopamine is what causes that piece of it. So that's the major one. And then on the other side, when we start dealing with organophosphates and stuff like that, it's the acetylcholine. Okay, that has the major effect. And we have acetylcholine all through our body, both on, if you guys remember back to the autonomic nervous system, what's the two parts of it? Okay, so you have the fight or flight, which is the sympathetic side, and the rest of the digest is the parasympathetics. Okay, that's everything. Acetylcholine deals with that. So those are the major neurotransmitters. But of course, we'll have some other stuff. Right? We're all addicted to something. I don't care what it is, who you are, you're addicted to something, okay? There's something that you take inside your body that activates dopamine, that activates the pleasure centers of the brain, and goes from there. All right? Abraham Lincoln. And then, so really Paracelsus, he's the quote-unquote father of pharmacy, okay? So a long time ago, he was an alchemist, that came through some beings and all that stuff. But really, everything, if we think about, is a poison. Anything that we take, it's just dependent upon the dose that we take. From the simple Tylenol that you can take for your headache, you take enough of it, 7 grams, you can kill your liver. Okay, chemotherapies, those things. They help the body, but they're all poisons. Coumadin, if you take Coumadin, what is Coumadin?
Rat poison.
It's rat poison. Mm-hmm. Okay, so that's all it is. So starting off, when you're dealing with just the overall general scheme of things, like everything else, before you get there, you know that you come across dispatch going, something's poison. What do we do first? Stop, pull out the binoculars, look and see. If you see white gas going on, okay, and you're in the farm country, what is it? Anhydrous ammonia. Are you going to go up there? No. Not unless you're in your full poppers or SCBAs and all that stuff. So again, stopping and thinking. Smokes, flames, and we're not talking about what's the major problems in a fire. What are the two major poisons in a fire? CO and what? Cyanide. Okay, so we're not going to talk about cyanide. If we get enough time at the end, we'll talk about CO. But then from there, other things, medicine cabinets, open the cabinet, there's a million one, containers. Spill containers, if there's damaged plants, so dealing with Jimson weed, talk about Jimson weed with some of the anticholinergic stuff, dealing with your salvia, just a whole bunch of things along that way. So even the different plants. And then, of course, drug paraphernalia. So the approaches, okay, so this is just the typical little person, kind of sort of how you think about different things. Temperature, looking at the lungs, is it wet lung, heart rates, fast, slow, skin, red, dry, versus sweaty. Do they have bowel sounds? All of our typical things that we, when we do our patient assessment. But a lot of times when it deals with the toxic patient, there's so many things that cross over, but then there's also so many things that are specific to the individual toxidromes. All right, and that's what the key factor is. So the remainder, of course, scene, check scene. Okay, what's our life threats? When you think of a life threat, what's the life threats? Do they have a airway? Are they breathing? And do they have a pulse? Okay, those are your life threats. If you can take care of those three things, the majority of the toxidromes that we'll talk about pretty much take care of themselves. All right, and then of course the person's talking, ask them what they took, how much did they take, when did they take it, how long ago did they take it, depending on what it was. Did they take it in combination with something else? Smoke a little K2, did a little crack, did a little all that stuff. Just having a good old speedball party.
Yeah, I can tell you all that.
The care, again, depends on the victim's size, their weight, medical condition. There's 8 or 9 drugs, single dose pediatrics. Okay, so there's certain medications that if a young kid takes, it's a killer. Okay, and we're not going to go through all that stuff because again, I can expand this to 4, 8, 6, 12 hours. We could talk about this. A lot of. Again, from the aspect of when did they last take it. When in doubt, this is the number. Okay, 1-800-222-1222. Okay, that's the local poison control. Utilize if you call with your cell phone. You might not, if you use a different cell phone other than Ohio. If you have a phone number that is from Florida, guess what?
You're in Florida.
Exactly.
So I'll get Georgia?
What? You'll get Georgia. If you use your cell phone, it'll actually bounce you to the location. That's how it's set up. And then they have to transfer you back to your local, and all that stuff. So if you use a landline, Columbus is our local poison control center and all that stuff. Toxicology in a nutshell, okay, the majority of toxidromes will end in this, okay? They'll go to a seizure, they'll go unresponsive, and then if we don't take care of the problem, they will die, okay? So if you can take care of that problem, you're good. Rest of the day, you can go home, bye-bye. Okay. And the majority of it is supportive care. I love this. Yeah. So how do we get stuff into our body? What's the 4 ways that we get things in?
Inhale, inject.
Inhale, inject, absorb, and ingest. All right? Yep. So inhale and ingestion, you absorb it, and then of course the injection in different ways of injections. And yes, it's a little kid that has a brownie. What's in the brownie? Little. Yes. Yum 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 yum. And that's a problem that they're having now in Colorado, California, and all that stuff. That the kids are actually getting hold of the brownies, and then they're having problems with that. But start them off young.
At least they're mellowed now.
Exactly. So the inhaled stuff, always take into consideration unusual odors. There's a lot of things. CO, do we actually have an odor with CO? No. So it's odorless gas and all that stuff. Do you smell fuels, hissing sounds, all the potential, facial burns and all that stuff? I had a gentleman when I was nursing a long time ago that was huffing paint. So he came in with blue and gold. His whole face was just covered in blue and gold. I was like going, hey, Michigan, God, I love it. But they do have, a lot of the whippets or the nitrous oxide or the nitrous that's in the different cans. So blanking on here. Put on top of pies.
Cool.
Cool Whip.
Ready Whip.
Yeah, the red whip.
Yeah.
I'm blanking there. Yeah,
Just before the
So
paint comes out.
exactly. So that has nitrous in it.
Okay. Lighting, Doc.
Yeah, exactly. Yeah, no.
I didn't know that.
So it has the nitrous that's inside the Ready Whip, and that's what they're inhaling. Okay, and that can cause other problems, like actually from the aspect of hearing problems and loss. Care for the most part, unless they're unconscious, dealing with that. Dealing with the ABCs and going from there. Find out what they took and how they did. Get them out, give them oxygen and air and all that stuff. On the ingestion side, depending on what type of food, what type of chemical they ingested, different food poisonings and all that stuff. So the common ones are salmonella and botulism. So this is the reason why kids, we don't give honey. Yeah. Kids under the age of 1 should not get honey because of botulism. Okay, being a foodborne. Yep.
I don't have kids.
Poisonings, different things. If they had food poisoning, abdominal pain, diarrhea, dehydration. And then again, some of them with the kids, if they got into mom, dad's pills or stuff like that, are they floppy? Are they having other problems and all that stuff? Ingested, okay? We do not induce vomiting, do not induce vomiting, do not induce vomiting, okay? From the other aspect too is now like, do you give them milk? Do you not? Give them water? Typically, you say nothing at all, okay? The majority of the stuff is that we don't deal with it. Some of the acids, if they drink the acids, it burns going down. You don't want it to burn coming up, okay? On the absorption side, different plants, of course, with the fertilizers, touching that. So your organophosphates, did they actually inhale it? Did they touch it? Did they put their hands inside the organophosphate poisonings and all that stuff? And then your cocaine, putting it in your nose, putting it up the butt, depending on which way you want to go. Blotter paper that would deal with the LSD, PCP, and all that stuff, putting it under your tongue and going from that. Care for that. More, of course, the majority of it is a poisonous plant. It's the chemicals that's inside the wounds. So you can actually, when you're dealing with the poison sumac, poison ivy, and all that stuff, you want to make sure that you're wearing your gloves, goggles, all that stuff. And then they can auto-inoculate themselves. So if they touch it, they can spread it all over the place. Most of the chemical side, if it's dry, what do? Brush it off. If it's wet, we water it, okay? And then knowing that some dry chemicals do not like to get wet, so be careful. Otherwise, on the injected side, depends on, is it a self-injection? Are they using heroin? Are they using other medications? Do you have to deal with the bites and the stings? Again, laundry list. This can go on and on and on and on about stuff. So what's a toxidrome? It's a poison, okay. So when someone says, what is the cholinergic toxidrome? What's the anticholinergic toxidrome? What is the opiate toxidrome? So what's a toxidrome? Okay. So I'll give you a definitions, okay. So toxidromes by themselves is a group of constellation of symptoms based upon specific poisonings, okay? Versus the syndrome, group of symptoms consistently occur together or condition characterized by a set of associated symptoms. So they kind of sort of go one and the same, okay? But really from the aspect, the toxidrome is based upon a specific poisoning, right? And then from there, not toxin, but really it's all based upon the assessment. And we have the essential five. Okay, yes, there's some others, but really from the big piece of it, these are the five major ones. And if you think about it, there's really the six pieces of our assessment-wise. All right. So the heart rate and blood pressure. So the heart, depending on what receptor is being activated, the respiratory rate, your temperature, your pupils, your bowel sounds, and then are they sweating? Okay. So if you go down to the sympathomimetics versus the anticholinergics, it all looks the same except for the sweating. And the anticholinergics, so they're, when we talk about that one in a little bit, they're dry, okay? Versus the sympathomimetics, they're sweaty, okay? So that's the cocaine and all that stuff. So really, that's the piece of it that we're going down. So anticholinergics, all right? The major classical thing that we'll deal with, okay, is atropine. Okay? What medication has atropine in it that you guys can administer? What? Nope. Epi, not atropine. Two things that you guys can administer that has atropine in it. You can't give atropine by itself, but as an EMT and EMR, you can give. In the farmland?
I don't live in farmland.
What?
I don't live in farmland.
All right. So this is going to be your Dewey Dotes or your Mark ones. Okay. That has atropine. It's atropine and prolidaxin together, which we'll talk about. All right. So your anticholinergics, really from the perspective of what they are, is the atropine, the belladonna, some of the mushrooms, but your antihistamines, okay? Benadryl, okay? High doses of Benadryl will cause an anticholinergic property, okay? So your old people that they want to go to bed, what do? They take a sleep aid, okay? Then they're still awake. Okay. Then they take another one. Then they're awake. They still take another one. And then they another one. Oh yeah, by the way, my Tylenol PM. Okay, what's the PM in it? Okay, that's diphenhydramine. It's one of the sleep aids. So I take Tylenol PM with a sleep aid. Okay, so they just overload it. That's how they get to where they are. It's pretty much there's two different receptors when it comes to on the cholinergic side or the acetylcholine. Again, what we talked about, really the major neurotransmitter for all of this is either dopamine or acetylcholine. Okay, so it's the muscarinics and the nicotinics. We'll talk a little bit more about that. Well, those are the two receptors for the acetylcholine, and then from there, it doesn't really do much for fun. Okay, they don't get much excitement out of taking a whole bunch of Benadryl.
Just like sleep.
Yeah, exactly. So the toxidrome. Okay, so it's hot as a hair, dry as a bone, red as a beet, mad as a hatter. Okay, so they touch them, they feel hot, they're really dry. Okay, going back to that one page that I had in there, they have absolutely no sweat on them at all. Okay, they're red, and then of course, mad as the hatter. Okay, hallucinations, amnesia, psychosis, and all that stuff. From there, they also have wide eyes. They might have double vision, okay? Going back down to what did we talk about earlier about the aspect of all toxidromes end in seizure, coma, death, okay? So they'll have seizures, go into coma, and then ultimately respiratory depression and death. Causative, whole bunch of different things. Again, Benadryl, some of our antipsychotics, skeletal muscle relaxants, your Flexeril. If you guys ever taken Flexeril? Had before? So Flexeril is a tricyclic antidepressant, and or similar to those. And that's has that potential problem. And then Ginseng weed, okay, which they do have locally. Okay, so. On the pesticide side, okay, this is the cholinergics. Okay, so if you from the major piece of it, organophosphates in our area is what we typically think of with the cholinergic. So any of our pesticides, sarin gas, VX gas. So the rock, you saw the movie Rock. That's the VX. And then some of the herbicides. Black widows, their poison that they inject with is a cholinergic. So you can have some of the same problems. And then nicotine will cause this piece of it.
So we got 20 patches.
Yeah, exactly.
Try to go
So again, going down on the autonomic nervous system, okay, so going back to that piece, so it's on the parasympathetic side, it's the muscarinic and the nicotinic receptors. Two different type of receptors depending on what they actually do. Okay, the major one, of course, that we see with the sludgems that we'll talk about is on the muscarinic side versus the nicotinic, which is more of a heart rate issues and all that stuff. A lot of these patients, of course, they feel anxious, tremors, vision disturbances, but then depending, we'll talk about is it central versus the muscarinic receptors versus the nicotinic receptors and all that stuff. So on the central receptors, okay, they get agitated, psychosis, confused, and then everything leads to seizure, coma, death. Okay. The nicotinic, okay, it actually got its name from, okay, or how it affects nicotine. Okay. So what they did is how they found this was they gave rats nicotine, and then they figured out which receptors. Yeah, exactly. Okay. So they were giving rats and all that stuff. So that's how they found those receptors, and they figured out that it's one of the cholinergic, or it actually affects acetylcholine. So if you activate the nicotinic receptors, okay, you give someone nicotine, what do? They wake up, They can go from there. They can get their blood pressure up. They get the tachycardia because it activates not just the cholinergic side of it, but then from there we'll actually go down the pathway of activating other receptors or other things. There's some pathomimetic sides, epinephrine and all that stuff. And then you can have some weakness and paralysis if you get a whole bunch of it. Okay. Versus the muscarinic, okay, the muscarine, the mushrooms, one of the mushrooms is how they found this, was giving, someone said, hey, let's take some of this and see what happens. Okay. And this is where we get our sludgeum that we talk about in EMT school and all that stuff. Okay. So organophosphates, salivation, lacrimation, urination, defecation, GI, emesis, and meiosis. Okay, so wide-eyed pupils and all that stuff. But what kills the patients when it deals with the organophosphates, okay, it's the three, okay, the killer bees. The bradycardia, bronchospasms, and bronchorrhea. Okay, so their airway constricts, their blood pressure or their heart rate drops, and then they get a whole bunch of fluid. Okay, so when we get a farmer that took a whole bunch of poisoning, okay, they dip their hands in the pesticides and all that stuff. It's those are the three that kills them. Okay? So how do we treat these people? What's the first thing? Any good poisoning, what's the first thing that we do? We must what? Come on, hazmat people.
You're gonna remove them from the hazard if it's not really relevant to here, but
Correct. But let's say someone brings something in that has, a life threat. Someone brings an organophosphate in or all that stuff. So yes, remove them from the hazard. And then after that, what's the first thing that we do after removing them from the hazard?
Decon.
What? Decon and all that stuff. All right. So decontaminate, and then we deal with, okay, vitals, which would include your ABCs. Okay. Make sure that they have airway. Okay, and then if you have the ability to obtain all the other information that you need to.
Circulation now.
What?
The BACs now.
For cardiac arrest, yeah. If it's a cardiac arrest, yes, BAC. Okay. If it's a not cardiac arrest, airway is still important. Potential. All right. So your advanced therapies for the cholinergics. Okay, really from the aspect of the antidotes, and we'll talk a little bit more about the antidotes. Okay, from there, our ALS friends, the potential of pushing atropine by itself, or pushing praladaxin by itself. It's on there. The 2-PAM is on the guidelines, but the majority of the departments are not carrying 2-PAM by itself. And then from there, if they start having seizures, like everything else. Everything leads to seizure, coma, death. So if they start having seizures, benzodiazepines are our drug of choice. Versed, Ativan, all that stuff that our advanced EMTs can administer, and then transporting these patients. Okay. In the field, I always tell them that if you get a true organophosphate poisoning, if you have the do-don't, you'll use the do-don't, and then you will waste all the atropine that you have in your box to administer for these patients. You'll take them to one of the local small hospitals, and they will probably run out of atropine, depending on how bad the organophosphate poisoning is. Antidotes time, okay. Do-we-don't is the major one that we have now. It's 2.1 milligrams of atropine with 600 milligrams of praladaxin versus the one above it, the Mark 1 kit. The Mark 1, you had to take the two things, spin it around to be able to put together. So they got injected with 2 needles versus just one with the do-we-don'ts. The Mark 1s is 2 milligrams of atropine and 600 of praladaxin, so a little bit more than the do-we-don't. But those are our drugs. Or, again, with the paramedics, they can administer the atropine and praladaxin separately. So how does atropine work? Okay. Again, for you guys as EMTs, you don't have to specifically, but you do need to know because of the do-we-don't. Okay. It's an anticholinergic. Okay, so you're actually taking those patients and causing them. What was the anticholinergic toxidrome? Dry, red, mad, hot. Hot as a hare, red as a beet, mad as a hatter. Okay, all that stuff. All right, so that's what you're causing them to, ultimately what you want them to have. So those individuals, they'll get the blurred visions, the tachycardia, decreased sweating and all that stuff. All right. And how much do we actually, or what do we do? Okay, it's really so much of all the effect is on the muscarinic side. And the muscarinic, that's the sludge, that's the killer bees. Okay, it doesn't really, atropine does not do anything at the nicotinic side or the nicotinic receptors. It has no effect there. So they're still going to have potential fasciculations. They'll still might shake and all that stuff. Their pupils will be affected and all that. So how much do we give? How much atropine do we need to give for patients that have organic phosphate poisoning? Feeler. What? So start them off 2, okay? But really, how much atropine do you want to give them? You want to give them enough atropine until they do what? These individuals are wet. Their lungs are wet. They're foaming at the mouth. Until they, exactly, okay? You want to give them until they dry out. How much is that?
A lot.
A lot, okay? 2, 4, 10, 12, up to 20 milligrams of atropine, which on average, if you think about it, we have someone that just has a low heart rate, we're giving them 0.5 milligrams of atropine. Okay, so you're giving these huge amounts of dosages. Okay, and again, we don't really worry about the heart rate and all that stuff. Who cares about the heart and all that stuff if you can't breathe and you drown? It's one of those things. So what does 2-PAM do? And again, just from the aspect of, for you guys, 2-PAM comes along, and if you think about it, it's a brake, one of the metal brakes and all that stuff. So it comes in where acetylcholine is bound to the receptors or the nerve agent. Let me back up. Acetylcholine esterase. So the nerve agents will come in and binds, and it doesn't let acetylcholine esterase do its job. So 2-PAM comes in and it pries the nerve agent off. Okay. Then from there allows for acetylcholine esterase to get in, hits the acetylcholine, breaks down acetylcholine, and we don't have the problems anymore. Okay. That's the overall pathophysiology of it. Symptoms of the 2-PAM, of course, the double vision, headaches, high blood pressure, hyperventilation, because you're knocking off or you're causing acetylcholine not to do its job anymore. Okay, so it's because it's being broken down and all that stuff. So they get the reverse effect, which is a lot of the anticholinergic side. All right. The drug world. All right. So if you're breaking through the drugs and all that stuff, so much of what we have when we're going down is, well, is it this? Is it that? Exactly how do some of the things? So when we talk about ecstasy, okay, your MDMAs and all that stuff. Ecstasy has properties of some hallucinogens. It has some properties of the stimulants, so it has a little bit of the sympathomimetic side of things. So it really depends on where you are. Okay, look at the in the middle with the cholinergics, your muscarine, nicotine, and all that stuff. It has a little bit of some of the antipsychotic side of it. It affects some of the stimulant side, the depressant. So it has a really, again, a nice barrage depending on what we are. Okay, but again, going back to the aspect of the toxidromes, so your anticholinergic, the cholinergic, and then when we talk about the sympathomimetics, and then the hallucinogens are actually the sedative ones, and then ultimately the opiates side of it too. So drugs. Drugs are good. Actually, I think drugs are bad. All right.
I've heard call that a long time.
What?
Grass.
Okay. All right. So the opioid syndrome. Okay. Again, on the toxidrome, all that stuff. So CPR is your little mnemonic. All right. So are they conscious? to look at their pupils, and then from there, we'll look at the respirations. Okay, so the opiate toxidrome. Okay, are they talking to you? Someone just shot up some heroin. Okay, are they talking to you? No. Okay, they might have shot up, fell backwards, hit their head, split their head wide open, got blood everywhere. We think that this is a trauma, but then from there we see the needle and all that stuff. Okay, pinpoint pupils. So really the pupils, they're less than, or they're approximately 1 millimeter, 1 to 2 millimeters is the typical pinpoint. So the size of a dime, if you put a dime on end, okay, that's what the size of what a pinpoint pupil would look like. And then the depressed respirations, right? And of course we can also see decreased blood pressures, temperature, reflexes. Everything gets slowed down, okay? So talking about the whole aspect of with receptors and how the receptors work. So what are opiates? The term opiates and all that stuff basically means to make numb. They originally got their name from the Greek god Morpheus. So he's the god of... You guys don't know your... okay.
Greek mythology, no.
What?
Greek mythology, no.
So Morpheus is the god of sleep. All right.
That's my house every day about 5 o'clock.
Matrix.
Yeah.
Oh.
Yep. Matrix and all that stuff. Yes. So Morpheus is the Greek god of sleep. So the morphine, it actually activates, or the receptor inside the brain, they call it the mu receptor. So the Greek Morpheus M, that's how it got the mu receptors. That's how it got its name. Okay. And what actually it does is the mu receptors get activated and they produce a chemical called GABA, which is gamma aminobutyric acid. Okay, so GABA is the slow down. Okay, body slows down. Versus the glutamate, body ramps up. And that's a different lecture that I have. Okay. For what it's worth. All right. So we got some smack.
Wow.
We got some skag. Okay. We got some junk, and then of course you get the brown. Okay. Different names for heroin and all that stuff. Deaths. Okay. Mortalities. 1994, 2014. Okay. If you look at poisoning, accidentals, all that stuff, 9,500 versus with accidental poisonings, all of that stuff, 9,200. So huge amounts and all that stuff. Versus, okay, car accidents, 6,800. Okay. So Ohio is number 1 in the country for opiate-related deaths. Okay, we are first in something. God bless.
Isn't Toledo like right towards the top?
Yes. Yeah. So percentages, again, this is just dealing with in Ohio 2010, 2015. What happened back in 2010, 2011? Okay, on prescriptions, with prescriptions and all that stuff. Basically, 2010, 2011 said, hey, we're having a lot of problems with prescription opioid. What?
Is that where they started limiting how much you...
Correct.
Whatever.
Yep. So they started limiting what we could do and all that stuff. The governor came out with, this is the best practices. And then so you saw prescriptions drop down. But when you see prescriptions go down, what happens? Everything goes up, okay? And then from there, fentanyl, the drug dealers in Mexico, they actually figured out that they can synthesize fentanyl. So that this is what the carfentanil that you'll hear a lot. And they found out that they can synthesize it for a lot cheaper than making heroin and all that stuff. And it's 1,000 times? It's 1,000 times more potent. I can't remember the exact numbers. With the fentanyl, the carfentanil, all that stuff. So huge problems. So they're making a lot more money. Hey, no problem. Okay? People need their fixes and all that stuff. So diacetylmorph, okay, aka heroin, okay. So this is the INN, is the diacetylmorph. It's an opiate. The British name, or the British approved name, is dimorphin. It was synthesized in 1874. They actually did an extract of from poppy plants. So morphine comes from poppy, okay, and then from there they took morphine, they took it into the chemistry, did some changes around it, and that's how they made heroin. Right? It actually got its name from the German word Hirsch, which means to make strong. That's what they thought they could give their soldiers some of this stuff and be better off and all that.
Yeah, there you go.
The purpose, of course, people were ingesting poppy, which was addictive. So they said, "Hey, we'll make morphine from poppy to get people off of using poppy," which was more addictive. Then they created heroin, which they thought would be less addictive than morphine to get people off of morphine. Okay, and that's how they came up with heroin. And then they took it one step further. Okay, and they used a synthetic form with the fentanyl, okay, to get people off of heroin, okay, which is even more addictive, okay. So that's the natural progress of all that piece of it. So this, again, goes to the aspect it binds at mu, okay. Heroin sold as a white powder. They split it in different things, okay. They cut it. So in the Texas area, that's almost 100% pure heroin if you go down there. So not a lot of bad problems. So what they do there is because they want to make their product better, or actually make it last longer. So they'll take the heroin, they'll cut it down, they'll put cornstarch, they'll use lemon juice to cut it, or they'll cut it with other things, which is the carfentanil and all that stuff, which is really cheap, and then they can make more of it and send it and ship it and all that stuff. So why do we use, or how do we use? Okay, so if we think about it, it's becoming more pure, and it's cheaper. The typical dose, 0.1 gram, is a typical thing, a piece of it, 15 to 20 bucks. Okay, so depending on what they're using. Most people on a daily basis use about 0.2 to 0.3 grams a day. Okay, so and there's been known that some people up to $250 to $300 worth of heroin a day is that they're using. Okay, so doses amounts. Shifting roles, of course, we're going away from the injection no longer, more to the snorting because people just don't like that, all the problems with injecting. So, but the issues with that is they don't get the huge highs that they do with the injections and all that stuff. So it depends. Okay, average age. Okay. Or the what you're looking at, it's the middle class white males, the traditional users and all that stuff. Teens to 30s. Statistically, in this area, it's more of the late 20s, 30s, early 40s is the age groups. Male, definitely more than female, and then it's mixed between the races and all that stuff. So how do we get it in? Okay. Again, injected more skin popping, muscle popping, all that stuff. Okay, the skin pop is actually they'll go under the skin just like they do a tetanus shot and inject a little bit of heroin there. Okay, what's the fastest route of getting it in? What? Yeah, the injection and all that stuff. Okay, that's why depending on the users and all that stuff, they want to go down that. If you inject it, the effects 7 to 8 seconds. Okay. So rapid onset, for the effects. Gets into the brain, it's very lipophilic, so it'll cross the blood-brain barrier, and then the brain starts having a party and good to go from there. Okay. Smoke it 10 to 15 minutes. So this is all the effects, depending on prescriptions versus heroin. You get some sleepiness, confusion, a little bit of nausea, pain relief. Heroin, might have some itching and all that stuff. That's why some of them have their some in the stores because they're scratching and all that stuff. And then both of them will cause euphoria, and then ultimately both of them will cause breathing problems. Okay, breathing problems. They stop breathing. Stop breathing. Then they die. Okay. So we do have some CNS depression. Okay. Respiratory depression, pupil problems, blood pressure drops, heart rate drops, hypothermia. There is some cases of pulmonary edema from injecting heroin, not a huge and all that stuff. And then ultimately everything leads to seizure, coma, and death. Okay, this is last year here in Ohio. If you don't know that, I mean, nothing like having your grandchildren in the back seat while you shoot up and all that. Okay. So how do we treat? What's the first thing that we do? What?
Breathing.
Make sure they're breathing. Okay. So what's the best way? So before that, what do we want to make sure? Like all good poisons, what's the first thing that we want to ensure? Okay, scene safety. All right. From there, after that, we want to do open the airway. Okay, what's the good ways of opening the airway? Okay, head tilt chin lift. What else can we use? Jaw thrusts, OPAs, NPAs. Okay. BVMs, oxygen. Okay. If you have the ability to obtain IV access, of course, monitoring glucose, and then administration of your naloxone. Okay. How does naloxone work?
Blocks the receptors.
Blocks the receptors. Okay. So when you block the mu receptor, okay, what do you stop? Well, you stop the euphoria. You stop the high.
Effects of the drug.
Okay. So what receptor are you breaking? That's the GABA. Okay. So the gamma aminobutyric acid. So you stop GABA. GABA goes down. Glutamate goes up. Okay. So glutamate is our excitatory. Woo! Okay. When someone gets a whole bunch of glutamate, what do? Their heart rate goes up. They get the urge to throw up. Okay, so that's what all the effects or the problems with that, or the complications of when we quickly reverse opiates, is because you get the surge of adrenaline and glutamate, norepinephrine, and all that stuff. Okay. So why do we want to educate? Of course, we know that most individuals do not use alone. Okay, there's usually is somebody there with them. It's 9 times out of 10, it's like their friend that takes the drugs and goes running off, or they push them out the car, and the gangsta Cadillac, or yeah, exactly. Or actually, it's the gangsta ambulance. I think is what it's called. So it does from the aspect of opportunity to treat and all that stuff. Most overdoses are minutes to hours before problems occur and all that. So then, of course, it's reversible. Okay. So naloxone go through training, of course. Always consider safety for your guys' standpoint, where you are, what you're getting into. Is the car running? Is it, I've seen that before, that they had the car in drive, and then they shoot up and they pass out at the at Starbucks, parking lot. And the car's, up against so it's still running. So take that into effect. And then like everything else, ABCs. All right. Naloxone by itself was developed in the 1960s to combat the problem. They feared the problems. It's a pure opiate agonist. From there, it has no psychoactive, so it doesn't enhance dopamine. So if you don't enhance dopamine, then you don't get the euphoria. There's no euphoric effects and all that stuff. And if anything, it actually potentiates the withdrawal symptoms. How does it get in there? Naloxone will competitively bind to the opiate receptors. So it has a higher affinity for the opiate receptors than the opiates themselves. So it gets in and holds on. Okay. After time, it says, I'm tired, and it just lets go. Okay, and then if you have enough opiate still inside your body, okay, opiates will come back in, bind to the mu receptors, and party continues. Okay. How do we administer it? Okay, you can put down the ET tubes, IM/IVINs. Effects usually within 2 to 8 minutes. And we've got some literature here in a second. It lasts 30 to 90 minutes. Okay. On average, they say about 45 minutes that the effects of naloxone will go. Okay, fentanyl, heroin. How long does their effects last? How long does it stay in your body? Okay, 1 to 2 hours. Okay, so it has the potential. Okay, that you can have a return to the overdose. Even though in San Antonio, Texas, they did literature a year and a half ago looking at that. And they had no deaths reported, okay, after the administration of naloxone and letting patients go bye-bye. Okay? So that's why we have the whole aspect now of the AMAs in the field for patients. If they're awake, alert, oriented, understand what's going on, okay, we can't force them to go to the hospital like they did 4 or 5 years ago. They can say, screw you, have a good day, I'm leaving. All right? So differences between IN versus IV with your clinical responses. Okay, 4.2 minutes plus or minus 2.7 versus IV 3.7 minutes plus or minus 2.3. So you have about a minute difference, okay, at best. Okay, if you're putting an IV in and all that stuff. So that's after IV's already there and administering the drug. Okay, how long does it take to start an IV?
That's what ALS people are.
What?
Depends on the patient.
Okay, so we have a patient that is an IV drug user.
No, that's gonna be hard.
It's gonna be a while.
Okay, so you're already, so that 1 minute that you're saving
Rhino just-
on the intranasal, over the intranasal piece of it, you're actually losing it by the or by putting in an IV. Okay, so going down that pathway of really, why they're saying, intranasal is not, as bad as the IV or equal responses, because by the time you put the IV in and go from there, and we can quickly assemble a device. And now they have the aspect of the 4 milligram single dose that they can get. Just open it up, put it in, squirt, you're done. There's no assembly required. So when do we use it? Okay, who are the people that we use it on? Okay, individuals that we think that took. Okay, that's the first thing, is that we have to assume that there's an opiate. Okay, they have to have some form of impending cardiorespiratory problem, i.e. they're not breathing. The 2015 AHA states that unresponsive or unconscious, potential pupils, and then either they have a respiratory arrest or they're not breathing well enough. Okay, breathing 2, 3, 4, 8. Okay, anything less than the 18 to 20. Okay, because we know all patients breathe 18 to 20 a minute.
I think everybody's blood pressure is 120/80.
Yes, everyone's blood pressure is 120/80. The made up numbers that I always see.
Be a lot easier to back the squat if it was.
Yeah. All right. So if the person's talking to you, and I've had this question before, med control calls, hey, got a person that's talking, okay? Do you want me to administer naloxone? The answer is no. Okay. So when do we give it? Is when they are unconscious, unresponsive, not breathing, with presumed opiates. All right. Things that we do have to take into consideration, okay? If they are a chronic user, okay, and you pull with them completely, pull all the opiates and all that from them, they're going to have a very bad day. They're going to go through withdrawal symptoms. What are the withdrawal symptoms that they have? So they're not breathing, so they're going to, yep. So vomiting, what else? Seizures, potentially. Not so much seizures, but they have, it's more the benzos, benzo withdrawals, but they can have a bad day. So they pee on themselves, they poop on themselves, their heart rate goes up, they become tachycardic, tachypnic. Okay.
Excessively pissed because you took their high.
Yep. Excessively mad and all that stuff. Right. We have seen patients actually go into have heart attacks. There's something that's called flash pulmonary edema. And that's usually, those ones are more affiliated with the IV form of naloxone when that is administered versus the intranasal. Of course, like everything else, the benefits of intranasal, okay, you don't have to worry about the complications of putting an IV in, okay. IVs themselves are risky, especially with some of the chronic users. We don't know if they're HIV, hepatitis, they have other diseases and all that stuff. And then we know that clinically they have the same effectiveness. Right. Within the guidelines, of course, state of Ohio requires, it's a mandate. Must have medical control within the procedures or your guidelines protocols. And then from there, of course, you have to go through training and all that stuff. We did training a year and a half, 2 years, actually, 2 years ago now? So it's been a little while. So this is why we're going through refresher courses and all that stuff.
Hey, Mark, do you want some?
What?
Mark, do you want some?
On the BLS, it's in Tab 8 Guideline 22 and on how to use the intranasal medications. And the ALS is the Guideline 42. All right, dosages of all that stuff, 0.5 to 4 milligrams. This is your typical dose. Pediatric is 0.1 milligram per kilogram to a max of 4 milligrams for the pediatric dose. Or that ideally, if you're doing it intranasally, no more than 0.5 milligrams at a time. Okay, so your naloxone, how does it come prepackaged? Yeah. So those little orange boxes, how much is in it? 2 milligrams and how much fluid?
2 milliliters.
Correct. Okay. So it's 2 milligrams and 2 mLs. Okay. So it's a half a milligram per half of ml. So if you think about it, the ideal dose when we go through using the MAD is a half of ml per nostril. Okay. So this is the MAD if you've never seen it. It's no longer on national shortage, and go from there. So the device, of course, that's your atomizer. Okay, this is your pre-filled naloxone, 2 milligrams per 2 ml in the little orange boxes. Of course, now they have the police and all that stuff. They can get the 4 milligram intranasal to go down that. Your lure lock system. Just go down, you take off the yellow cap, you take off the little brown on the back, and then the Bristojet or the pre-filled ampoule. Sometimes it's a purple cap versus an orange cap. Screw it together. Be very careful that you're not screwing too hard. So if you screw too hard, what's going to happen? Exactly. Okay, you're actually going to spill the medicine out. So just put it on gently. Attach your mucosal atomizer to the device. Put it into the nostril, turn to the ipsilateral ear. Okay, so the ear, if you're going to the right nostril, point it to the right ear, and then just give a quick spray. Okay?
Or stream.
Or stream, depending on.
In that
Your
case,
ad device
that
doesn't
lovely
work.
stream that went down my throat.
Yeah. All right. Again, first line, slower onset versus the IV form, but it depends on what it is. Accessible for non-users, no IV sticks. Okay. Technically, I think when I put this together, is not FDA approved, but I think it is now to that point. And then 40 to 50, I mean, that's being very generous at the cost now. Again, this is kind of sort of what it looks like. Make sure that you are wearing your gloves, okay? And what else should you be wearing? Okay, your eye shield, eye protection, all that stuff, okay? Because after you squirt this, what's going to happen to them? Okay, they might wake up. So if you think about it, okay, the administration of naloxone, it's a balance act, okay? You want them balanced enough between respiratory drive and
It's a level of consciousness too.
okay, correct. Okay, so on one side we have our respiratory drive or level of consciousness, and on the other side it's the withdrawal symptoms. Okay, because like everything else, if we give too much of it, they can have withdrawal symptoms. Nausea, vomiting, again, they do have a potential seizures, and a lot of that in the pulmonary edema is again with more the IV form of it. So we don't want this. Okay, and then from there, from the aspect of you call a acute, if you do a acute withdrawal, especially for the pregnant females, you can actually cause them to go into preterm labor, fetal distress, placental abruption, all that stuff. Okay, because everything contracts down. All right, and then for like everything else, okay, potentially naloxone bad, airway good. Okay, and then from there, what this person really needs is suction and plastic between the vocal cords. Okay, That's what this person
Not
means.
stupid.
And then other potential things always take into consideration, okay, from the aspect, did they overdose? But did they overdose, hit their head? Or had they been down for so long that, they have, low blood sugar? Are they in sepsis and all that stuff?
I love when you go to a nursing home, they have no narcotics on their med sheet, but yeah, you get a Narcan, there we go.
Yeah.
So, yeah.
A couple things. All right. I used this one this morning.
Death wish coffee.
Yeah. All right. So we talked about the cholinergics. We talked about originally with the anticholinergics. We talked about the opiates. Okay. And then from there, now dealing with the sympathomimetics. Okay. They have two different ones. Hitter's the one that I kind of sort of like. They also have another one called MAFs as for the mnemonics as to what the toxidrome. Again, with these individuals, hallucinations, insomnia, tremor, tachycardias, and then the speech and restlessness, all moving, all that stuff. All right. From the aspect with again, going back to the anticholinergics, okay, what was the anticholinergic? Okay, anticholinergic, they were, how does the hair?
Where does it be?
Red as wheat,
Yeah.
mad as a hatter,
Driving.
dry as bone, okay? So they're dry, okay? So again, the anticholinergic and the sympathomimetics, they look very similar, okay? It really is dealing with the sweat side. These ones are going to be sweaty. The anticholinergics are going to be dry. Okay? But they're still kind of sort of go from there. So who do we think about? Okay, from the perspective of our first classical and all that stuff. Okay, our meth. Okay, Mickey Mouse having a bad day. Okay, so what's meth? Meth is a synthetic. Okay. Different terms and all that stuff. If it's snorted, called speed or crystal. If you smoke it, you get crank or ice or glass. Traditionally, 6 seconds is what you can have. And then from there, symptoms can last 12, 24, then up to 36 hours that you can have symptoms and all that stuff. And it's been known to keep people awake for 16 to 20 days straight. Okay. Having a good day. It is the pleasure city, pleasure center. It's highly addictive. That's why, and it's actually fairly cheap to make. They had documented cases of an individual making meth inside the Walmart before.
Make them in backpacks walking down the street.
Yep. The bottles and all that stuff. Yep. So again, from the perspective of the pleasure center of the brain or the pleasure neurotransmitters, again, it's that dopamine, increased dopamine, you get all the pleasure and all that stuff. Okay. Signs and symptoms. Hypothermias, from the aspect of energy, speech, loss of appetite. Okay. They have that, intense cravings, the tweaking and all that stuff. Other things that they'll have: tachycardia, violence, hyperactivity, paranoia. It's a bad day for them. Treatment-wise, most of the stuff, of course, is really dealing like everything else. Okay, if it's a bad meth, okay, if it's a meth lab or something like that, okay. Scene safety is the utmost. Okay, what's the problem with these meth labs?
Bump something, cause an explosion.
Yeah, exactly. Okay. Like everything else, WC's, a lot of it's just supportive, IV access for the advancing EMTs and paramedics and all that stuff, monitor, and then really just calming or ensuring, talking the patient down. Okay. And then quiet transports.
Do it yourself. Oh.
You know, taking pictures of your childhood games.
It's amazing what
Wow.
you can find. It's amazing what you can find on Google. All right. So coca, Pretty much from the aspect, I mean, that's how Coca-Cola came about, its name and all that stuff. It had a little bit of cocaine in it. Cocaine has been forever day, back to the age, they have documented reports in Egypt and all that stuff. It's been around forever. Pretty much in the aspect of 1916s, they put it in tonics, toothaches, and all that stuff. From the aspect of for when the nose is stuffed up, red and sore. Okay, it's still to this day used. There's still a number of physicians that'll use it for nosebleeds, a 4% version of it. So it really does depend. Cocaine, like everything else, what does it activate? Which neurotransmitter? The pleasure one. The pleasure one is dopamine. Okay, it's a stimulant. It's again, it comes from the coca. It's a white powder. Unlike the heroin, they'll cut it in different ways. Cornstarch powder and all that stuff. This is how they even the aspect now on the crocodile. You guys have heard of the crocodile?
Codeine.
What?
The codeine that they put in it.
Yeah. So codeine and also they're actually with the crocodile. The cleaners in the red matches. So the strikers from the matches, that's what they're cutting it with. That's what people are injecting inside. It does have the aspect again with dopamine. It's neurotransmitter, long acting. It's that pleasure center. Wants to do that. And then from the aspect of you're injecting it or you're snorting. If you're injecting it, I mean you're injecting vinegar, injecting lemon juice. So it's not the cocaine that's causing the problems. It's the other things that they're cutting it with is the major problem with things. So how do we get it in? Okay, snort injection. Okay, rub it in the mucous membranes. That's if you look at your thumb and all that stuff, the little spot between the two tendons. Okay, that's actually called the snuff box. Okay, why is it called the snuff box? You put a little bit of your medicine in there and you sniff it up. Okay, that's how it got its name. Signs and symptoms, of course, euphoria, hyperactivity, psychosis, dilated pupils. They can get tachycardia, seizures, like everything else, seizure, coma, death. There's been known patients, of course, with developing chest pains and even going into having heart attacks and all that stuff. Treatment, okay. What would you think would be the major treatment? Calming them down. Before that, we want to ensure scene safe, air breathing circulation, calm the person down. Okay. Using monitors, oxygen, IV access. Okay. And then the major treatment, if we have our ALS friends, okay, our advanced EMTs and our paramedics, it's the benzos, okay. Giving them the benzos decreases the sympathomimetic response, so it calms, okay. Calm them down, takes care of the chest pain, okay. We're not giving, if they're having chest pain with this and they use cocaine, we're not giving them nitro. Of course, everyone does get their life-saving aspirin, okay? But really, the major therapy, if they're having cocaine-induced chest pain, is giving them Versed, Ativan, Valium, calming them down. Of course, make sure to treat, okay? It's okay if it's there, but that's not the major therapies, okay? If they're in a cardiac arrest situation for the paramedics and all that stuff, lidocaine used cautiously because cocaine is a sodium channel, does affect the sodium channel just like lidocaine. MAG, if they're combative, fighting you guys and all that stuff, a number of the departments are carrying ketamine. So here locally, if you had someone that was really bad off using cocaine, they'd come in and put them down in the excited delirium state. Okay, hit them with some ketamine or any of the other stuff, and then a lot of benzos just to sedate. Okay, 0.5 to 5 is the typical, and then 2.5 to 10 for the Valium. Okay. Out in your neck of the woods. Okay. So bath salts, Okay, Cloud 9, White Dove, Vanilla Sky, Blue Silk, Snow Leopard. It keeps coming and keep coming and keep coming. Those are all different variations of the same medication, and what they'll do is the methadone, MDPV, or your methylene dioxypyroverone. That's why MDPV. What they'll do is they'll take it. They will make it. They'll synthesize it. They will sell it in your head shops as bath salts. And what are bath salts? Something that is nice and calming and soothing. Of course, what do we? Well, not what do we. What do people do with it? Okay, they ingest it. They put it up their butt. They snort it. Okay, they do a whole bunch of different things. So from the cat plant, they developed all the methadone. In America, they've made it illegal for that synthetic. So what they do is they'll change the chemical, and then they have a new compound. And then they'll change the chemical, and they'll have a new compound, and that's just how they get around it. So typically it's 200, 500 milligrams, and it's labeled as not intended for human consumption. When someone says labeled as not intended for human consumption, what does the first person do? Exactly. All right. Somebody will try something. Head shops, gas stations, tobaccos over the internet. Okay. Methadone. Okay. Again, it's plant food. Okay.
Oh, people today.
Why? This is why. Okay. They want to do it because they get the euphoria, the sociability. Okay. They love it. It feels good. It makes them good. It's a stimulant. They get some sexual arousal. They have some music appreciation. Okay. But from there, they do have hallucinations and all that stuff.
Bass music, I guess you do need some help with that.
Okay. Has not really been from the aspect of, they're not, they might be doing it now from the aspect of giving rats like everything else to see exactly the complications of it. But why do we need to give rats when we actually see it from humans? Hey, the rats are going, hey, great, I don't have to deal with this. How we do it, sniff it, snort it, oral, okay, they inject it, okay. And again, aspects like everything else, dopamine is the precursor. Dopamine that gets converted to norepinephrine, epinephrine. Okay, like all the other things, the pleasure center of the brain is the receptor, the neurotransmitter, dopamine. Okay, dopamine's the neurotransmitter. Okay, GABA is the slow down. Glutamate is the build up. Okay, and then your cholinergics and the anticholinergics is the acetylcholine. Signs and symptoms, like everything else: chest pain, strokes, nosebleeds, delusions, paranoia, seizures. Okay, seizure, coma, death, ultimate things. So a whole bunch of different problems, like all the other typical sympathomimetics. Okay, high heart rates, they're acting weird, they don't know what's going on, they're out of control, they're impulsive, and they're just going and going, can't stop, keep going. Okay, they're actually talking faster than that. How do we treat it? Okay. How do we treat? What's the first thing that we want to do? Sing safe. Okay.
Sing safe in the popo.
Okay. Getting our sing safe. After that, what do we want to do? ABCs, like everything else. Then from there, that's a lot of supportive. Give them some oxygen. Okay. If we have this person, if he's sitting there in front of the speaker going, hey, it'll be okay.
He's appreciating the music.
Yes. Okay. Where he does not want to be, though, we want to get him away from that area. Okay. Because this is a sympathomimetic. A sympathomimetic does what? It enhances the body, so they're, they have that paranoia and all that stuff. They don't like a lot of the noise, so getting them in the back of a nice, quiet ambulance. Do we need 7, 8 people in the back of the ambulance with him? Okay. This is the time period where if you're in the back of the ambulance, all that stuff going, hey guys, okay, we don't need people coming in and out, and all that stuff. IV access, and then from there, monitor, and if necessary, okay, calming them down if they're bad. Okay. Benzos, ketamine, Haldol, all that stuff. Put them down, chill them out. So we talked about anticholinergics, cholinergics. We talked about the opiates. Okay, going down into the aspect of we just got through the sympathomedics, so the cocaine, your basalts, and all that stuff. Now getting into one of the final ones, and then we'll add a little bit into the psychedelics and all that stuff. Okay, so the sedatives and the hypnotics. Okay, the sedatives, of course, is anything that calms you down, sedates you. Okay, this could be anything from anesthetics that we give to some of the benzos and all that stuff, or other medications. So Benadryl, okay, Benadryl in one piece of it by itself, if you take one or two of them, okay, they make you sleepy for the most part. Okay, the flip side of it, I mean, yes, some people have adverse and all that stuff. Okay, so they'll actually will wake them up versus they can take a whole bunch of it and it becomes an anticholinergic. Versus the hypnotics, those are the ones that the arousal or the sleep cause that whole piece of it. Okay, your Ambien, Lunesta, okay, those are part of the sedative hypnotics. What do they do? Okay, all of this, again, I've been talking about GABA. Okay, this is alcohol. Okay, what does alcohol do? Alcohol is a GABA. Okay, so if you think about, you drink a whole bunch of alcohol, what do? You go to bed, or what's your speech like if you drink a whole bunch of it?
You don't talk.
You don't talk well, you're slurred of speech, you get the double vision. Hey, 10 and 2, I can drive. 10 and 2, keep it between, okay? So your coordination drops, your staggering, stumbling, all that stuff.
I did it once.
What?
Fell in Andy's fire.
Every time I have one, I gotta have people over because I will fall in the fire.
Wow.
I did it once.
Alrighty.
I broke the fire pit.
Nice.
You broke the fire pit?
Yeah.
All right. So,
I didn't get burned.
so depending on what it is, okay, some things might be a sedative, some might have a little bit of hypnotic effects as we keep going. Okay. So again, from the aspect, a lot of the drugs, like we've talked about, depending on what it is, ecstasy versus, the benzos. I mean, everything has so much crossover. That's why that one picture with the 4 different pieces and all that stuff, I mean, it does have some variability depending on how much you take and all that stuff. So typical benzos, barbiturates, and then your zolpidem, which is your Ambien, Lunestas, and all that stuff. But we can't forget about rufinol, which actually is a benzo, but it's really kind of sort of by itself, because we don't really talk about rufinol or roofies and all that stuff at the same time that we talk about Versed and Ativan. Just the two don't go together, but they really are. Rufinol and the roofies is actually it's in a benzo family, and then GHB. And you can even throw in here nitrous, if you wanted to throw nitrous in here. But again, like everything else, we've had a lot. But nitrous is another one of your sedative hypnotics that the dentists like to use in kids and all that stuff. Right? Why benzos? Okay. If you talk to my wife, she would love to take care of this or take this all the time. Okay. Just for the simple thing of getting away from the stress and the screams and all that stuff. So actually, the songs, who was the artist? I can't remember. Mother's Little Helper?
Stones.
What?
The Stones.
Yeah, okay. Rolling Stones. So actually there's a song about Mother's Little Helper, and that's what this is. It's all about benzos. Okay? 1973, 100 million prescriptions. Women used it more than men. And then, of course, with the concerns for abuse and all that stuff, it's been going down. A lot of people still use Xanax and Ativan and all that stuff. Seizures, Valium, help out with muscle spasms. But Xanax is one of the crack cocaines of the benzos. It's a very highly addictive drug and all that stuff. Still used as a anti-anxiety, anti-stress medications, all that stuff. Like everything else, okay, it's benzos. Its whole purpose is to slow the body down. Okay, GABA. Okay, not gabba gabba. Okay, GABA. Okay.
It's making kids TV show.
Yeah, that's what I'm thinking. Like some little
Yeah.
black guy in a spandex suit.
Okay. GABA is the inhibitory transmitter. Okay, dopamine is the pleasure. Glutamate is the excitatory. Okay, GABA is the inhibitory. Okay, and then of course acetylcholine is the part of the rest and digest, the parasympathetic part of the autonomic system, and also has effects with the sympathetic sides. Right. It also does a little bit affect the RAS, which is the reticular activating system, which is our drowsy system. Okay, that's our level of consciousness when that gets going. And the motor cortex, it'll slow down the motor cortex, and that's how we get floppy. Okay. Short effects, of course, it has euphoria. People like it. It does, it will activate both the GABA, but then from there it also does the dopamine, so they get pleasure from it in short amounts. If you take a whole bunch of it, okay, at one time, what do?
I fall asleep.
You fall asleep, okay. If people take a whole bunch of it at one time, if you watch us, push 5-10 milligrams of Versed, what do? They fall asleep, and then ultimately they stop breathing, okay. So it depends on what effects you want. It does slow down the breaths, okay. So it is dose dependent, depending on what you take. The hypnosis side of it, you get a little hypnotic, and then from there, benzos has a tapering effect that it'll get to the anesthetic side, so the body doesn't know what's going on. Versus the barbiturates, barbiturates can actually take you into a coma, and then ultimately, if you don't have an airway, death. Okay. Out of all the potential, okay, or the major drugs and all that stuff, there's only a couple of them that we have to actually worry about withdrawal. If you withdraw from heroin, what happens?
Chills, sweats,
Yeah.
shakes, start up.
Yeah, but do you die? Okay.
Not even.
LSD, do you die from the withdrawals? Typically not.
Yeah.
Okay. Ecstasy, you really don't die from the withdrawals.
Yeah.
You get the Tuesday blues.
Yeah.
Okay. Benzos, like alcohol, okay, are the two withdrawal symptoms that can actually kill. Okay. So those are the ones that we have to be careful about withdrawing. And this is one of the reasons why that we don't have flumazenil or romazicon in the pre-hospital setting like we do with Narcan. Okay. If you throw somebody with the withdrawal symptoms, okay, what's the biggest withdrawal problem with benzos? All the toxidromes leads to seizure, coma, death. Okay, you will throw them, if they withdraw, you'll throw them into a seizure. And how do we treat seizures? Benzos. Okay.
And just kind of
So you cause them to withdraw from a benzo by giving them a medication that you can't give because you caused the withdrawal. That's why we don't do that. Okay. Therapies, safe ABCs, okay, IV, okay. And if they're having bad withdrawal symptoms, all that stuff, giving them benzos and giving them antipsychotics. Okay. Yes, they can act like Godzilla. Rufinol, okay. It is by definition it's a benzo, okay, but it really doesn't have much of a medical treatment, all that stuff. Okay, so actually, Rufies is a Schedule 1 medication. It's odorless, tasteless. It comes in a little white liquid that you can put into people's drinks and go from there. Okay. Sedative, it does have the same thing. If you got roofied, yeah, we can test for it, but we really don't because go from there. Usually the symptoms, supportive therapies, like all the other benzos, intubate them or give them oxygen and they'll take care of the problems. And then, of course, the aspect of cases. GHB, the gamma hydroxybutyrate, also your Georgia homeboy, your grievous bodily harm, so a whole bunch of different things. Again, it's a GABA. Bodybuilders do use it. It will enhance bodybuilding properties and all that stuff, or the testosterone going from there. But really, like everything else, they take it for the aspect of drinking, for the euphorias and all that stuff. So my first case that I ever dealt with GHB was back in 2000 where they, after the fact, they're actually taking it in the emergency waiting room, and the two of them fell asleep, and we ended up intubating one and all that stuff, which is an interesting thing. I guess that's the best place to take it, you know. Like everything else, euphoria, the dizziness, they'll get some bradycardia, respiratory depressions, and then if it's bad enough, seizure, coma, death. Consider about the positional asphyxia, like all these, the benzos, alcohols, and all that stuff, depending on where they are. You know, make sure that they're on their side. That way they don't vomit and all that stuff. And then respiratory problems. And then from the aspect of mimicking alcohol intoxication with the GHB. More drugs. All right. So our psychedelics, okay, comes from, again, like everything else, the Greek side of it. It's the soul, manifest the soul and all that stuff. And they have a lot of excitement and just seeing things and just, man, feels good and all that stuff, okay? Of course. So LSD, okay, lysergic acid dimethylide, okay, 1938s, okay. It was extensively used in the 40s and 50s, okay, CIA, Navy, and all that stuff, okay. Ultimately, it was taken to immunize themselves from the effects of the 60s, okay. So if you think about it, that's real good job satisfaction, okay. And we're still seeing the effects of it now, okay. So how do we take it? What's the typical way that we do it? LSD? What? Orally? Okay. How do we do that? Yep. Piece of papers and all that stuff, the blotters. Okay. Sublingual, oral on the papers and all that stuff. All right. Yes, you can sub-Q or IV and all that stuff, but it's not there. They'll put it on their sheets and they'll cut it up and then they'll dispense it and go from there. So really, 50 to 200 micrograms is your transcending dosages, even up to 500 mics. Okay. So what do we look like? Okay. Dilated pupils, vivid auditory, tactile, visual perceptions. Okay. This is the seeing sounds and the hearing lights. Okay. Dude, I can do that. Okay. They will have some nausea. They might have some drops in blood pressures, and then, of course, the aspect of the stimulatory effects and all that stuff. Okay. Piloerections, bradycardias, and the pre-existing behavioral tendencies. Okay. How do we treat it? Like everything else. Okay. Okay. Oh, sorry. Your insomnias. Okay. They get the jitters. They get flashbacks. Okay. They can actually, there's been some reported cases and all that stuff that after one hit, they'll actually will have flashbacks for potentially the rest of their life. That they'll have this, don't know what's going on and all that stuff. So treatment, like everything else, okay? ABC, scene safety, going from there. A lot of it's just supportive, protect the patient, okay? Calm, low-key, low-light environment. Calm. Low light, low key environment.
So you're saying it's not a code 3 run?
Calm, low key, low light. Oh yeah. By the way, really, how do we take care of this? Dude, calm it down.
Is LSD considered addictive?
It does have the properties of being addictive. It will have some dopamine, pleasure centers, and all that stuff. Yes. Yep.
So we're giving some burritos and
sitting down in the corner.
Yep. Okay. And if you do if they're really agitated,
Let them watch the wall.
yeah. This is not the this is not the person. If you're going into the emergency department at St. Vincent's, you don't put them by the nurse's station.
Oh God.
This is not the person that you want there. Okay, the one that's right there in front, you don't want them. This is the person that you put in the back. You just turn the lights off and calm everything down. Not next to the screaming kids. Okay.
Can we put this one in the waiting room?
Hey, okay.
I'm leaving now.
MDMAs, okay? So, oops.
Oh.
So different things, different pieces, all that stuff. The NMDAs, the methamphetamine. This is the rave drugs that were coming through and all that stuff. Typical age 12 to 17. Again, it's the friends going out. You might get it something into the early 20s and all that stuff. But really, it was the aspect of Molly. I don't know if you guys ever heard of the Molly and all that stuff. So the Molly, the thought, what?
They put them in pills too.
Yeah. So Molly, the thought, was the pure form of MMDAs. So ecstasy is your classic MMDAs. That's the one that we always have. But then Molly came along and going from there. Okay. But then from there we have other things. Ketamine and dextromethorphan are also kind of sort of in that same family of the MMDAs and all that stuff. So Molly's not a pure MMDA. It actually has other things that's been put into it to go from there. So what does it do? Okay, it's the feel-good drug. Okay, it has properties again of some amphetamines in it. It has properties of hallucinogens, and really its piece is blocking the serotonin along with dopamine. Okay, dopamine again is the pleasure center. Okay, serotonin also has part of our pleasure center and all that stuff. Okay, so what Prozac, Paxil, all those block serotonin. Okay, those are our mood stabilizers. So serotonin is the mood. Okay, dopamines are pleasure, along with the part of the excitatory. GABA's the slow down, glutamate's the build up or the excite. Okay, so now we have the serotonin, which is our mood neurotransmitters. Okay. So when people take it, 15 minutes, they get the rush, 2-3 hours, fatigued, or they can have the plateau and then fatigued, okay? They get really excited. They go. They have fun, okay? And what's the problem when it comes to all the excitement when they're in a rave? What else are they doing? They're dancing, okay? Are they drinking?
Sweating.
They're sweating,
Drinking
okay?
a lot of water.
So what's the problem? What's the complication? What happens?
Dehydration.
Dehydration leads to cardiovascular collapse, then to death. Okay, that's how they've had the number of deaths that related to mollies and MDAs and all that stuff. You can't have the Tuesday blues, so you take it on Friday, take it on Saturday, and then the symptoms get out of the body, and then the serotonin, because you lose the serotonin, that excitement, the mood and all that stuff. Ooh, okay, and then they get the Tuesday blues while they're in school and all that stuff. So if you have children and they're using it and they're just depressed on, they feel great on Friday and Saturday, but then they're depressed on Tuesday and Wednesday, something to consider.
They also use nasal inhalers to enhance it.
What?
The nasal
Yeah.
inhalers to enhance it, the effect.
Okay.
Like,
Using like a buterol or?
yeah,
Okay.
to enhance the effect of it.
He's using albuterol and all that stuff to enhance the effects of the NDAs. Okay. I'll have to do that one. I'll have to look that one.
Don't have to do that.
You do that and you let me know.
Let me back that up. I need to look that one up. No. Okay. Okay.
Wife wants benzos and he wants.
He wants ecstasy with
Literally
that.
describe the effects unless you do them all.
Exactly. Well, there's a website that a lady I can pull up and show you guys that all the stuff that she did in her life, she actually has gone back and gotten her master's. But everything that she did, she has gone and described the effects and all that. So, videos and it's kind of interesting. MMDAs, it does have the hallucinogenic, the psychedelic effects, and that's why they take it. But then from there, it also has the sympathomimetics. That has that crossover. Okay, so they get the tachycardia, the hypertension, all that stuff, and that's how they die. They go through the cardiovascular collapse and death and all that stuff. Okay, they'll get renal failure, and then like everything else, leads to seizure, coma, death. Okay, Treatment-wise, cool them down, benzos for any of the agitation, convulsions, and all that stuff. Okay, IVs. Okay. Into the hallucinogens. Okay. Ketamine. Okay. It's been around for a little while. Special K, vitamin K, cat Valium. It's a dissociative anesthetic. We're actually now using it more in the hospital, in the pre-hospital, just for the effects that we want to in controlling patients. It is, by definition, it's a sedative hypnotic. It's an anesthetic. Really going down that. For us, or for the patients, okay, it's really, they want the K-hole side of it, okay? It goes in different levels and all that stuff. So again, it's a transcending dosages. So you give a little bit, okay, feel good, they get the euphoric, and then they get too much of it, and it actually can split their brain from their body. So that's how the aspect of, yeah, exactly. So they get that whole euphoric type side, and how they go into it is how they come out of it. So if they're in a great state, they're feeling good, everything's good, they go in great, they come out great, they get just vivid dreams and all that stuff. I've had patients, little kids, playing basketball against Michael Jordan, and I mean just living it out and all that stuff. So depending on what it is, the flip side of it, they go in bad, they come out bad. That's how they get they become agitated and violent, is when they're coming out of the ketamine usage and all that stuff. Treatment, if they have the aspect is, beneficial for the dystonias and benzos and all that stuff. It is a good medication from the aspect that they can actually protect their airway, but it does increase the blood pressure, increase the heart rate, and all that stuff. PCP, okay, rocket fuel, ozone, superweed, okay. Very similar PCP with ketamine. It has that same, they're in the same family of drugs and all that stuff. Solid liquids, powders, they can inject it, smoke, okay. Sprinkle it on a little marijuana, some tobacco, okay. This, okay, like everything else, it has a whole bunch of different properties with that. Anticholinergic, dopamine, okay. It has some opiate type things, so it does activate the muse and all that stuff. Ketamine does the same thing, and actually has some pain property with that. GABA, so it really, stops the GABA, so it has a whole bunch of different pieces and all that stuff. DXM, dextromethorphan, okay. You can buy it over the counter. Well, let me back up. You can ask the pharmacist. Okay, you don't need it as a prescription, but you can.
Change NyQuil?
What?
Didn't they change NyQuil recently?
I'm not sure about NyQuil. I know that you can get Robitussin DM still.
Yeah, but
Yeah.
I think they changed NyQuil because the old Green Death formula doesn't knock you out for 2 days anymore.
Yeah. Well, it's the Green Death formula is because of this and the DXM in it. I'd have to go and look and see. I know that Robitussin, they still make a Robitussin DM. You can actually get DM by itself. It's a cough suppressant. Okay. But like everything else, they figure out, hey, if I take enough of it, okay, we have good euphorias and highs and stuff like that. So kids, that's what they would go to grab, just like your ready sprays and all that stuff. Okay, salvia, sage of the seers. Okay, it's a plant. Okay, people are still growing it to this day and age and all that stuff. Okay. And it does have a whole bunch of different little effects by itself. Hallucination, smoking early, ingesting it, okay, laughter, confusion, speech. What we want to, exactly, what people do. Okay? Like everything else, it does have its dangers. Kids are drawn to it, freak out, they injure themselves. So like everything else, when dealing with this one, if they smoke the salvia or they have it, low light, calm, keep everything nice and down and all that stuff.
I just saw that the other day. It was like EMS or something like that. Posted that.
Marketing, right? So K2, okay? Still around and all that stuff. If you actually go on their website, our K2 and Sense can help promote through aromatherapy an atmosphere that indulges a sense and comfort and relaxation. Okay? Yeah, right. Okay.
You know.
Okay. And of course, the meditation, all that stuff. So really, by names, okay, Bliss, K2, Moonrock Skunk, Genie, Mad Hatters, a whole bunch of different things that come through. And again, it's the whole thing with the bath salts. It is not intended for human consumption. Okay, they're supposed to put it in and it's aromatherapy. Okay. We still have it from the aspect here. Okay, smoke it, brew it in teas, all that stuff. Again, from the aspect of marijuana, it's more of a fat soluble, so it'll stay in the body longer and all that stuff. Signs and symptoms, like everything else, get paranoia. Okay, 40 times, it's huge hallucinogenic effects with K2. They'll get the panic attacks similar to marijuana, the giddiness, why they take it, the tachycardia, euphorias, and then ultimately, like everything else, leads to seizure, coma, death. Okay, and then they can actually have something called a serotonin syndrome. So they get a whole bunch of it, this huge serotonin rush. A lot of serotonin in the body is not a good thing. Leads to tachycardias and EKG changes and death and all that stuff. Okay? So how do we treat it? Like everything else, quiet, calm. ABCs, a lot of it's just the support of oxygen if necessary. Quiet, quiet, quiet if they need it. If they're really bad freaking out, benzo is going to be your drug of choice. Okay. Are toxic alcohols, okay? And yes, people do drink all these different ones, okay? So ethanol, which is the main one we have, ethylene glycol, methanol, isopropyl, okay? And then acetone. Okay. Ethanol, okay? Our general treatment for all of this is really from the aspect of taking care of the issue and the problem and all that stuff. Alcohol by itself, no problems, they're good, unless they have other things. If they have alcohol-induced lactic acidosis, or if they're drinking the methanol. In the emergency room, we do have famipazole, which is a direct competitive inhibitor of alcohols. Actually blocks one of the enzymes that converts alcohol to whatever. Okay. Death can ensue if not treating all that stuff. So ethanol by itself, okay, this is our drinking alcohol, okay. It inhibits the NMDA, okay, so again, it inhibits the glutamate, okay, which it's the GABA, so it's the slow everything down, okay, really down that pathway. So if you think about it, just on your levels, your 0.05 euphorias, they're feeling great, okay, 0.08 is your can't do much more, it's the legal limit and all that stuff. At 0.1, you have CNS problems. 0.3, stupor, unconscious. 0.4, possible death. I think the best that I had was someone who was 0.47. Okay. Walking, talking.
Wow.
What we consider a professional. Okay. So, that's, 47% of the person's blood, okay, was alcohol.
0.3 was the highest I've
Yeah.
had.
So, ethylene glycol, this is your antifreeze, or one of. Again, ethanol itself is converted to just as a sugar, and then the sugar is metabolized out and all that stuff. Ethylene glycol, that in your antifreeze, they not so much, people don't drink it for the effects. They actually, the problems or complication is it tastes good, or it has.
I know animals, it's like sweet.
Yeah, so exactly.
They changed the antifreeze too. It's not poisonous to plants and animals anymore.
Well, that's another version of it. It still has.
No, but I felt a lot better when I had to change my rating.
Yeah. But yeah, for animals, it actually is sweet. That's how a lot of them actually would kill the animals and all that stuff. So it's converted to oxalic acid. Oxalic acid actually will form crystals. Crystals will get into the kidneys and kill the kidneys, so they'll go into renal failure and all that stuff. So and then from there, they can also have the meningoencephalitis, so they get confused and wacky and all that stuff. The one that they're kind of sort of going to now is getting into the propylene glycol, okay, which it's the safer antifreeze. Actually, propylene glycol is in a lot of food additives, so you can actually go down your toothpaste, hair shampoos and stuff like that will actually have propylene glycol in it. Okay, so look and see. Okay. It's a safer because it's actually, instead of being metabolized into oxalic acid, it's actually metabolized into lactic acid, and our body can do something with lactic acid. Okay, it'll shove it back into the Krebs cycle and go down that whole pathway. The diethylene glycol, that's what your brake fluid is. It's metabolized into HEAA, okay, and that causes renal failure and all that stuff. Okay. The one that we actually have to get worried about, because people will drink this. Okay, so they can't get a hold of ethanol. We'll get into using some of the wood alcohols. So your lighter fluid, the butanes and all that stuff, some of those will actually, it's a form of methanol. Okay, so they'll actually use the wood alcohol. It's converted into formic acid. Formic acid is horrible for the body. Okay, so the people that are drinking some alcohol, then they start having visual problems. Okay, I can't see and all that stuff. Or they're saying everything just like snowfields, okay? They drank wood alcohol. Bad. Will lead to blindness, permanent, and all that stuff. All right? Respiratory failure, then they have some of the Parkinsonians. Okay? Isopropyl, okay? It's converted to acetone, okay? And then from there, they'll get some depression. It is 2 times your ethylene, your ethanol, the effects and all that stuff. So kids, by accident, they'll drink the isopropyl alcohol that we have, okay, in the little white bottles and all that stuff. Or people, again, they can't get a hold of regular alcohol, so will steal this from the, Rite Aids and all that stuff, and they'll drink this.
The original absinthe wood.
What?
Absinthe, back the original version of it, the wood grain, wood.
I don't know.
It's psychedelic.
It still is.
Well, now it's a different form of it. But
If you go to Europe and
It's
get absinthe,
still the
it is the
same.
original absinthe.
Okay.
That's why they can't sell it here in the United States.
It's that good?
You can't let it touch your tongue, or it will cause all the symptoms that you just read off.
Excellent. And of course, there are some other glycols that can cause pancreatitis, ARDS, which is acute respiratory distress. Right. So finishing up, all right. Not truly one of the toxidromes, but in this area, this time period, something that we definitely need to make sure that we have some considerations about. Okay. So the invisible killer. Okay. Furnaces, heaters. We can also see this during the summertime with boating and all that stuff. Colorless, odorless, natural, non-irritating gas and all that stuff. All right. CO versus CO2. CO2 we breathe out. CO is a byproduct of burning fuels and all that stuff. And then if you get enough CO2, it can cause an asphyxiant. CO at low dosages, it'll disrupt what's called the electron transport chain in the body, and you can actually die and all that stuff. So how does it work? Gets into our body, displaces oxygen and all that stuff. CO is bound to oxygen more, 250 times more potent with that. And it doesn't allow oxygen to be delivered and all that stuff. So just having a bad day. Okay. Who's at risk? Elderly. Okay. Unborn babies. So if there's been times reported that a CO leak in the house. Mom was pregnant. Okay. The baby went into fetal distress, woke mom up. Okay. And then headache and all that stuff. Got everybody out of the house. Everyone survived because of the effects to the baby. Of course, the baby survived and all that stuff too. So it's a good thing. Okay. Respiratory problems going from there. Okay. Firefighters. What? Yeah. Yep. It's happened before. Firefighters at scenes and all that stuff. Indoor working gases. Pulp mill stills. Okay. Pets, again, from the aspect, they're more sensitive a lot of times than us. So they, again, that whole piece of it. Common poisonings, of course, fall and winter months is the typical time period when we turn the furnaces on, and or from the aspect of going out to Put in Bay, drinking and all that stuff, everyone's skiing, going behind the boats and all that stuff. What do we see really from the aspect of the chimney chutes, the furnaces, indoor grills, from the aspect of having your grilling inside your garage during winter time because you want a nice grilled steak. Portable heaters and all that stuff. Cold weathers usually due secondary to insufficient ventilation, stove pipes, exhausts. They used to have your kerosene heaters and all that stuff. Improper ventilation. That's the only thing they have. That or if they, their furnace is broken, so they go turn the stoves on to get heat inside the house and all that stuff. That never happens.
No.
Warm parts, improper uses, charcoal grills and all that stuff, heating homes, gas ovens. Okay. Warning signs, of course, looking at the house, so they have problems, streakings, burnings, and all that stuff. Issues with the draft soot, the falling in the fireplace. So if you're actually looking if they're burning fire and all that stuff, problems smoking inside the house and all that stuff. The big things that a lot of it is, of course, is the flu-like symptoms, okay? So if you have a whole household, everyone comes walking in at the same time, and we all have the flu, or, when I'm in home, I feel bad. When I leave, I go to Walmart, I feel great. I come back home, I feel bad again, okay?
24 hours, go to Walmart.
Yeah. So headaches is a classic. So 4, 5, 6 people in a house, especially this time of the year. If I have 5 people from the same house come walk in, we all have a headache. Stop, call a fire, have them go check out your house for CO. Warm weathers, of course, is an aspect of, again, like the ventilation side of it. And what typically I see is some of the lawnmowers and all that stuff is, again, inside. They're trying to fix things, get it working, and all that stuff. But typically it's the aspect of the boats, the platforms, and all that stuff. Okay, we have individuals that they are the cabin of the boat. The boat went back, and the exhaust was just circling inside the boat the whole time, and so a lot of different. Yeah, exactly.
Poor design for you.
It was poor design. All right. Again, symptoms can last depending on what it is. Minor dosages, age, and all that stuff to have to take into consideration. Effects, dizziness, emotional changes, and they get some depression and all that stuff. If you think about it, this is the classic. They'll get the headaches as a typical. They'll feel dizzy. They'll short of breath because again, it's displacing the oxygen. So they're not getting enough oxygen to the body. And then ultimately, okay, seizure, coma, death. Okay? Like everything else. Short term, okay? So if it's high dosages short term versus low doses long terms, it's that whole mantra of dose dependence and all that stuff. Okay? As the actual long term effects of the problems. How do we detect it? Okay? Like everything else, flu, okay, feel like the food poisoning. Again, if you have 5, 6, 7 people in the house, and every time you leave, I have it, I come back, it's that aspect. There was one of my partners, he had individuals that they were farmers, and of course they're fixing a tractor. Anytime you fix tractors, what do? What else do you do when you fix a tractor?
Put it in the barn, close it, and start that thing up.
Yep, you put it in the barn, you start it, and you drink. Okay, so they were actually fixing the tractor, starting all that stuff. They ran out of beer. One of them left. Okay, one of them left to go get beer. Came back, and his friend was unresponsive. Okay, so this is the one time that VWRUN actually saved the guys. Beer run. Okay, so he went on a beer run to get more, came back and found his friend unresponsive, called 911, and everyone survived. So beer at times does save. Okay, so what's our role? Okay, so what's the first thing that we want to make sure that we do?
Gas meter.
Gas meter. Before that, get the people out, SCBAs, use the oxygen, take care of yourself. Make sure it's safe, and all that stuff. We do have a lot of the new monitors and all that stuff. Cardiac devices have the ability to test for CO, which is a good thing for the cardiac monitors to have and go from there. Typical levels, anything under 10, definitely anything under 20 needs to be treated. Anything over 20, anything under 20, okay, oxygen. Over 20, depending on symptoms and all that stuff, if they're seizing, hyperbarics, and going from there, depending. The main therapy is really from the aspect of action. Okay, if you do nothing by itself, it's approximately about 6 hours for the symptoms and all that stuff to go away. Okay, you give them oxygen, non-rebreather, it's about an hour roughly. Okay, you put them on, intubate them, high flow oxygen, all that stuff. You can cut it down, and then the hyperbaric therapies. By the time that we can actually get somebody to a hyperbaric chamber and dive them, just intubating them will take care of the problem of the CO. Really, the hyperbarics helps some of the long-term or long-down effects that can happen from CO poisoning. Prognosis, of course, depending on what it is, how long they've been exposed and all that. And then from there, the aspect of the fetus, if mom is exposed and all that stuff, the alpha hemoglobin that's in the fetus has a much longer or a higher affinity even than ours. So it really grabs the CO, and unfortunately there's been cases of fetal demise from CO poisoning.